2009, a 24-year-old journalist experienced a rapid, catastrophic onset of paranoia, auditory hallucinations, and unprovoked seizures. Initial psychiatric evaluations concluded she was suffering from acute schizoaffective psychosis. Standard clinical treatments were administered, but antipsychotics failed to stabilize her. Her vitals crashed, and she slipped into complete catatonia. At this critical juncture, a neurologist stepped in, handed her a blank piece of paper, and asked her to draw a clock. The result was striking. She drew all 12 numbers crammed strictly into the right hemisphere. Psychiatric disorders disrupt the content of thought, but they rarely compromise the brain's ability to map physical space. This specific spatial neglect points to a failure in the parietal lobe, an organic diagnostic marker that indicates a physiological assault on the cerebral cortex. The psychiatric symptoms were the external manifestation of an active autoimmune response within the brain, Anti-NMDA Receptor Encephalitis. To understand how an immune response mimics acute schizophrenia, we have to look past the patient's macroscopic behavior and examine the microanatomy of the frontal cortex. This schematic shows an inhibitory GABAergic interneuron connected to a frontal dopaminergic pathway. Under normal baseline conditions, NMDA receptors provide the necessary excitatory drive to keep that inhibitory signal active. In this disease, autoantibodies bind directly to these NMDA receptors, causing them to be internalized and physically removed from the synaptic membrane. Without those receptors, the GABAergic interneurons lose their excitatory drive. The circuit's built-in brake completely drops offline. This disinhibition allows a massive, unregulated flood of dopamine and glutamate to surge into the frontal pathways. This highly specific chemical overload directly produces the hallucinations, paranoia, and cognitive fracturing typically associated with acute schizophrenia. The patient's psychosis is not the result of structural brain tissue degrading. It is a functional, downstream effect of localized GABAergic disinhibition. If the brain itself is structurally intact, we have to find where this targeted immune assault is originating. In over 40% of female cases, the origin point is located far from the central nervous system, deep within the pelvis. A scan of the pelvic cavity reveals a hidden paraneoplastic trigger, a benign tumor known as an ovarian teratoma. A teratoma is a germ cell tumor. Because germ cells are pluripotent, these tumors are capable of growing fully mature, differentiated human tissues, like hair, bone, or teeth. Looking at a histology slide of this specific tumor, we see standard benign ovarian tissue interspersed with highly distinct mature neural and glial cells. This ectopic neural tissue possesses fully functional GLUN1 subunits, the exact same NMDA receptors found in the central nervous system. By growing functional brain tissue in the periphery, this benign tumor unwittingly presented a foreign neural antigen to the immune system, painting a target directly on the patient's brain. The immune system identifies this out-of-place neural tissue as a threat and initiates a biologically correct defense protocol. B lymphocytes and plasma cells mobilize, generating a swarm of high-affinity IgG antibodies designed to attack the NMDA receptors on the tumor. Through a process called molecular mimicry, these circulating antibodies migrate through the bloodstream, breach the blood-brain barrier, and enter the brain environment. Once inside, the antibodies cannot distinguish between the ectopic receptors on the pelvic tumor and the identical GLUN1 receptors lining the cerebral cortex and hippocampus. The moment they bind, they trigger the exact receptor internalization and synaptic failure we observed earlier in the frontal lobe. The immune system is executing a perfectly normal humoral defense mechanism. It is simply executing it against an identical, unintended target inside the brain. This flowchart tracks the 4 stages of the disease progression. We can correlate the patient's escalating physical and behavioral collapse directly with the rising concentration of antibody titers in the cerebrospinal fluid. During the initial prodromal phase, the titer line begins to rise as the immune response starts in the pelvis, presenting externally as mild viral-like symptoms. As antibodies breach the blood-brain barrier, the titer line steeply spikes. This initiates the psychotic phase, driving the acute schizophrenia-like hallucinations and paranoia. When cortical suppression becomes widespread across the brain, the patient descends into the unresponsive or catatonic phase.
Finally, as the antibody concentration reaches its absolute peak, the patient enters the highly lethal hyperkinetic phase, characterized by severe autonomic instability, hypoventilation, and involuntary facial movements known as orofacial dyskinesias. The clinical deterioration is not random. The severity of the psychiatric and physical collapse is dictated strictly by the volume of autoantibodies circulating in the cerebrospinal fluid. Reversing this decline requires stopping the antigen source at its origin. This starts with the immediate surgical resection of the ovarian teratoma. This split-screen diagram illustrates the aggressive, multi-tiered immunotherapy required to clear the existing central nervous system assault. On the left, plasmapheresis and IVIG mechanically filter the circulating antibodies out of the blood plasma. On the right, the drug rituximab actively targets and depletes the CD20-positive B cells that produce the antibodies. Because this autoimmune attack is strictly receptor-mediated rather than necrotic, it does not destroy the underlying brain cells. The neuronal architecture remains structurally intact. Once the antibodies are cleared from the system, the surviving neurons simply re-express new NMDA receptors, slowly restoring normal calcium influx and synaptic function. Over a 12-month recovery timeline, spatial cognition and executive function return. We can see this in the progression of the patient's clock drawing tests, moving from severe right-side cramming back to perfect symmetry. Data published in the Lancet Neurology shows an 80% recovery rate when these early diagnostic and clinical treatment protocols are followed. Anti-NMDA Receptor Encephalitis demonstrates that severe schizophrenia-like behavioral collapse can stem from a fully reversible molecular anomaly, permanently bridging psychiatry and immunology. Next, we will investigate a neurological anomaly with no known reversal protocol, fatal familial insomnia.